I have no relevant disclosures, and I did not write the title to that talk. My English teacher would smack me if I had. Never end a sentence with a preposition, so I have edited it to reflect a more grammatically appropriate title, which is presented for your enjoyment. To get things rolling, I want to present a couple of cases. These are not real cases, but these were designed to bring out some educational points. Candidate number one. This patient was 81 years old at the time of transplantation, was transplanted 30 days prior and never really did well, had severe primary graft dysfunction, and was originally transplanted for IPF with a double lung transplant, is morbidly obese and is not recovering. Is on 100% oxygen, and despite that has a PCO2 of 90, is insulin dependent, has elevated pulmonary and right atrial pressures, has significant GERD, which was known about pre-transplant, now has a creatinine of 3 and an estimated FVC of 30% and is flat on her back. That's one of your candidates. Next candidate is a 24-year-old outpatient who is a mother of an 8-year-old, has, or a 7-year-old, has an FEV1 of 20% of predicted, is on 6 liters of nasal cannula oxygen at all time. Her PCO2 is starting to climb. It's now at 62. She's thin, but is on an upward trajectory with a BMI of 17.8 and has spent 3 of the last 4 months in the hospital. She's really struggling and has now had 2 episodes of fairly substantial hemoptysis. Her 6-minute walk distance has deteriorated over the last 6 months from just under 1,500 feet to now only 270 feet, and she's manifest secondary pulmonary hypertension. So which one do you want to transplant? Which one do you think is associated with a significant benefit versus potentially an exercise in futility? Well, if you believe the lung allocation score, we should transplant candidate number 1. Lung allocation score in this particular case using the online calculator is 88.3. And unfortunately for the second potential recipient who is in obvious need of transplant with excellent prospects for long-term recovery and meaningful outcome is only 41.2. You see, the issue is that in 2004, before we rolled out the lung allocation system, we were advised that it was self-correcting, where we balanced waitlist urgency against outcome. And unfortunately, we double weight waitlist urgency, so that instead of the score going down as people get so sick that it's an exercise in futility, the score continues to climb. And we have very little information about what to do in the upper echelons of lung allocation scoring. We do know, however, that lung allocation scores prioritize patients, and as I said, there's no cutoff that's been documented as a point wherein you're past the point of no return and lung transplantation does not offer a meaningful chance for a positive outcome. As lung allocation scores climb, so does post-transplant mortality. And if you look at quartiles below 50 or segments of the population below an LAS of 50, 50 to 74, 75 to 100. The outcomes at 90 days don't separate very much, but they continue to separate as you get farther out. And in data that was presented at the American Transplant Congress last week, you find certain interactions with lung allocation score. So if you have a score greater than 50 and you're more than 55 years of age, your prospects for a meaningful outcome are terrible. If your lung allocation score is greater than 60 and you're a retransplant candidate, your odds of surviving long-term are virtually nil. So lung allocation score does climb and does predict poor outcome, but it doesn't self-correct in terms of how we should allocate organs. With that said, I thought we would talk about a few hot topics. Now, these are areas where there may or may not be data, and I've done my best to examine the data that exists and make my recommendations balanced and data-driven. I think we have to avoid the temptation to look at single center experience or a single patient experience and view that as permission to proceed with high-risk endeavors, but rather let's look at these areas and try to come away with some meaningful lessons learned that we can take home. The areas that we'll talk about will be those patients that require ECMO pre-transplant, not to get through the operation, but rather for some period of days or weeks prior to transplant, they require ECMO support to maintain life. Those that are mechanically ventilated for some period of time prior to transplant, those of advanced age, those requiring retransplantation, and if we have time at the end, I will give you a smattering of advice about some other high-risk profile patients. ECMO was first used as a bridge to transplant in 1975. Not too surprisingly, original case reports suggested poor outcomes. Unfortunately, at the present time, there's an indirect and an inappropriate impact on the lung allocation system. When the lung allocation system was formulated, there was not sufficient data to tabulate in the impact of ECMO. So if you're on ECMO and when you enter ECMO into your lung allocation scoring calculator, there's no change in your score. But what happens is that patients who are on 100% face mask or 100% FiO2 are put on ECMO, their supplemental oxygen comes off, but instead of allowing their score to drop as would be ethically appropriate, programs leave those numbers as they are. They don't update the patient data. So patients have falsely elevated scores on ECMO and as a result get high priority. Probably as a result of that, we're seeing a significant increase in near doubling of the incidence of patients requiring ECMO support pre-transplant. Single institutional reports have been positive, and obviously expertise is going to beget better outcomes, but the UNOS registry data suggests otherwise. This data is not that old. It does include the entire cohort of 51 patients that are in the registry that were transplanted from ECMO, and they are propensity matched to 49 appropriate controls. And as you can see, the outcomes are pretty grim. At 24 months, the unsupported patients had a 70% survival in this registry report versus only 45% in the ECMO group. And in fact, the odds ratio for one-year mortality if you require pre-transplant ECMO support is 7. That's astounding. The cause of death in this cohort is primary graft dysfunction, 21%. Infection is also common, as are cardiovascular complications and multi-system organ failure. But things are getting better. Technology is advancing. We have much better oxygenators. We have heparin-coated circuits with low priming volumes, centrifugal pumps, and dual lumen cannulas now that avoid or minimize significant venous mixing so that patients are more ambulatory, systems are more compact, priming volumes are much lower, and indeed with the advent of pumpless ECMO circuit technologies such as Novolung and the artificial lung, this is not going to be the same technology 5 years from now, but the data that exists on a registry-wide basis is very limited. Only single institutional data is available. But as an example of the kinds of advancements that we're seeing is the transition from ECMO 1, which is depicted on the left, and ECMO 2, which is basically a much more modern oxygenator and a CentroMag pump head. And what we're seeing is that with lower priming volumes and heparin-coated circuits, we're decreasing the blood loss by half, and heparin dosing is cut in half as well. Now, admittedly, this is in a post-cardiotomy patient population, but it's a testament to where we're going and the fact that things are going to be different. Well, what do we know now? We know that we can transplant off of ECMO, but that posted post-transplant outcomes have been poor. It's allowing you to transplant the sickest of the sick, but it doesn't mean that they're going to do well. Use of pre-transplant ECMO should therefore be used very cautiously, and we definitely need to clarify the impact that ECMO is having on lung allocation scoring. In order to do that, we need data. UNOS and the SRT are actively collecting that data now, and this is a high priority for them. But ultimately, it will be multi-center data, hopefully prospective trial-based data, is going to be required to answer the question as to whether or not we should be doing this on a wider scale and how we drill down and find out how this interacts with other variables that define recipients as high risk. What about mechanical ventilatory support? Ventilator dependence was initially thought to be a strong relative contraindication to transplantation due to frequent airway microbial colonization, long-term immobility, nosocomial sinusitis, the higher incidence of deep venous thrombosis, significant swallowing dysfunction, and obvious risk of depression. Small series that are single-centered have shown no difference in post-op intubation time or survival. The lung allocation score appropriately does prioritize ventilatory dependent patients as their waitlist urgency is quite high. And as you would expect, the prevalence of mechanical ventilatory use in the post-LAS era has nearly tripled, or more than tripled. And this relates to the fact that we now have a hope of getting to these patients in time. When allocation was based on time on the wait list, there was no hope, and we didn't even entertain such patients, but now we're transplanting them in significant numbers. Unfortunately, and this is international data, it does pose a significant risk for 1- and 5-year mortality that is not insignificant. If you look at the U.S. data, we see the same trends, such that those that required ventilatory support prior to transplant, and this accounts for nearly 600 patients that were propensity matched to a similar number of controls, there's a significant drop-off in survival at the early and late time points. Well, maybe if we drill down and try to define subgroups that would benefit from transplantation, that despite being mechanically ventilated, we'd get closer to what we really want to be doing. As you know, cystic fibrosis is the most common diagnosis that's associated with mechanical ventilation in the UNOS database. These patients don't do well if you leave them on a ventilator long term because they can't clear their secretions and their lungs essentially become closed abscesses. However, cystic fibrosis is the listing diagnosis associated with the best post-transplant outcomes. Several small studies have been done in cystic fibrosis patients that were mechanically ventilated, and in adults there appears to be no survival difference despite the fact that they're intubated for a somewhat longer period of time after transplantation. In children, the outcomes are not quite as good. There is indeed a lower survival in the ventilated cohort and longer intubation times. So what do we know? We know that patients requiring mechanical ventilation are definitely at higher risk for early mortality. Ultimately, disease-specific models using large registries should be considered to define subpopulations probably identified by listing diagnoses that are appropriately considered despite the use of mechanical ventilation. And transplanting mechanically ventilated patients should be done with caution. Now, if you thought that Dr. Oringer was tough for making people walk 1 to 3 miles a day prior to esophagectomy, imagine being forced to push your ventilator around the ICU. And that's what we do. We get patients out of bed, they're nutritionally resuscitated aggressively, they undergo toilet bronchoscopy for quantitative culture analysis every 48 hours, and we're vigilant and palliative and spiritual care with them every day, and they push their ventilator around the ICU at least for 2 to 3 laps once or twice a day. So these patients are not allowed to get there and progressively deconditioned, and they are reassessed to maintain their active status at least every 1 to 2 days. So this is the kind of vigilance that's required if you want to have consistently successful outcomes in this population. Should there be an age limit? And this is a very hot topic, as programs are apt to tell you that they've transplanted an 80-year-old or an 85-year-old, and they say this with great pride. I'm not sure if that's all that wise. This is older data, but at one point there was an ISHLT consensus set of guidelines that said that they would endorse single lung transplant up to the age of 65 and bilateral transplant up to the age of 60. And this is based on the fact that traditionally the ISHLT registry data has showed a significant dip in outcomes after the age of 65. As of 2004, U.S. programs, about a quarter of U.S. programs, would still consider bilateral transplant for patients over 60, and a fifth of U.S. programs would still consider patients over the age of 65 for single lung transplant. If you're very careful and you really minimize concurrent exposure to other comorbidities, patients may do just as well in the older than 65 age group. This is a single study of 50 patients, some that were 65 years or older and some that were less than that, and the survival outcomes were fairly similar. At least they were not statistically significantly different. Not only that, the acute graft functional outcomes, incidence of acute and chronic rejection were the same, but a pattern was arising in that the most common cause of death in these populations was infection. If you look at registry data from the ISHLT, age greater than 70 appears to be the tipping point. The odds ratio for mortality is 2.3 in that subgroup, and with an annual excess mortality of 1.9, and again, in the international data, the most common cause of death was infection. So what do we know? Advancing age is associated with poor outcomes, and probably beyond the age of 70, one needs to be very, very careful. Some centers are reporting acceptable outcomes after careful selection, and I would emphasize careful. It's unclear where the age cutoff should be, but I would not be overly anxious to transplant patients beyond the age of 70. And given the risk of infection, it is unclear if immunosuppression should be altered, but in all likelihood, the intensity of immunosuppression should be reduced in that population. On to retransplantation. A couple of basic assumptions, basic facts. Every organ used for retransplantation represents an opportunity, potentially a first opportunity, lost for another candidate. Therefore, listing for retransplantation has the potential to exponentially grow. Retransplants have indeed increased in recent times, more so in the younger age group between 18 and 49, but in the 50 to 64 years of age group, the number of retransplants that have been performed has doubled. This is despite the fact that the outcomes, and if you'll pay attention to the lower right box, with a 5-year survival that is uncorrected at 22%, are not very encouraging. If you want to find out who to transplant in the retransplant context, one has to look at indication for transplant. If you stratify by chronic graft failure, airway complications, or primary graft dysfunctions as your indication, you find some differences that start to pop out. If you're transplanting for chronic BOS or chronic graft dysfunction, and you're more than 2 years out from your first transplant, your outcome starts to look a lot like your naive transplant. However, if you're transplanting for acute graft failure or airway complications, the outcomes are poor. Not only that, and this is somewhat older data, but the 1-year survival in uncorrected retransplant populations is only 47%, and risk factors for mortality include a non-BOS diagnosis and ventilator dependency beforehand. Therefore, the patient should be far out from their first transplant. It should be for BOS, and they should be ambulatory and not ventilated. Risk factors for the rapid onset of bronchiolitis obliterans syndrome include time less than 2 years since first transplant, ventilatory support, and low center retransplant volume. One other caveat, this is a study that looked at doing single lung transplants in the context of retransplantation, and in a significant number of patients, they left a graft in, either by transplanting on the naive side or doing a single lung transplant for someone who had previously had a double lung transplant. And the take-home message is in the red box there. These patients tend to get chronic bronchitis and often fatal infections. So leaving an old graft behind, while it may seem easy, particularly if you're operating next in the unoperated side, is folly. And you're going to subject these patients to a risk of significant infectious complications. Ultimately, retransplantation for primary graft dysfunction or airway complications has a high mortality. Retransplantation for BOS in selected patients could result in similar outcomes as the first-time transplant patients, and retained grafts are a site of infection and can lead to poor outcomes. These are the other areas I wanted to just mention briefly. There's a moving sand as it relates to how we address malignancy. Obviously, for advanced stage malignancies that are currently under treatment, transplantation is not appropriate. If you have a stage 1 lung cancer that is found incidentally at the time of native lung explantation, or that you're suspicious of it or you're following it, it actually doesn't affect your long-term outcome. But if you tip the scales to node-positive lung cancers, I don't think that's a particularly good idea, and certainly for stage 3 and above, the outcomes are disastrous. Bronchoalveolar carcinoma is another discussion, but that should be selected on a case-by-case basis. One other thing is that we don't really know about all the malignancies that patients carry as they go into transplantation. And just one haunting fact, 75% of the male population over the age of 70 has a microscopic focus of prostate cancer. So we're transplanting more people with malignancy than we know about, and I don't think we understand the breadth of the problem yet. Severe esophageal dysmotility is a significant impediment to successful outcome. Reflux disease and microaspiration insult allografts chronically and contribute to the rapid onset of bronchiolitis obliterans syndrome. So we should be fastidious in providing a mechanical or surgical barrier to reflux, not just providing acid reduction therapy. There are programs that are considering transplantation in patients who have absent esophageal peristalsis and wide open uncontrolled reflux. The strategy that's been proposed has been surgical laryngeal closure, permanent tracheostomy, and permanent gastrostomy tube feeding. You can weigh in personally on whether or not you think that that's an appropriate intervention and utilization of a precious resource. Coronary artery disease is a moving target. 10 years ago, people with coronary artery disease were not considered appropriate candidates for transplantation, didn't even make it all the way through the evaluation process. Now, particularly experienced centers have developed individualized strategies, largely that are catheter-based prior to transplantation, but some are embracing concurrent surgical revascularization at the time of transplantation. There isn't enough data yet to tell us which is the right direction, but I think we should be assertive and communicative with our findings in order to define the right pathway. Colonization with virulent organisms is going to remain a problem going forward. Experienced centers with CF care centers as well do well transplanting with B. cepacia. M. abscessus, however, is a bad bug, and with recurrence rates in excess of 50%, often associated with fatal infections, I'm personally not in favor of transplanting patients with M. abscessus. So in conclusion, pre-transplant ECMO is associated with a high mortality. That we know. More data will be required to figure out where that should fit in our armamentarium of support. Mechanical ventilator dependency also has a high mortality, but may be okay for specific diagnoses and ages, such as adult CFers. Advanced age is associated with lower survival, but may be acceptable with strict criteria for other comorbidities, but likely as not, there's probably going to be an upper age limit. Survival after retransplantation is not as high as it is for first-time transplant recipients, but it may be acceptable for some, particularly young patients with BOS who are far out from their first transplant. And ultimately, resources are limited, and every high-risk transplant potentially denies someone else with excellent opportunity for a long-term outcome. Insufficient data attesting to poor outcomes does not grant permission to proceed anyway. Surgical bravado has no role in organ allocation. And finally, professionalism, transparency, and self-criticism will be required to develop intelligent and transferable strategies and policies with regard to high-risk transplantation. Thank you.